Good morning, ladies and gentlemen. The topic of today's lecture is ectodermal dysplasias. By definition, ectodermal dysplasias are a large group of heterogeneous heritable conditions that are characterized by congenital defects in two or more ectodermal structures, one of which at least involved hair, which is also called as tricho-dysplasia, teeth, dental defects, nail, onychodysplasias, and sweat glands dyshidrosis. Mesodermal and occasionally endodermal disturbances of development may coexist. So in short, ectodermal dysplasias are those congenital disorders in which one or two or more of the ectodermal structures are disturbed, dystrophic, or absent. Introduction and general description. Ectodermal dysplasias form a complex and highly diverse group of heritable disorders. As outlined by Veach, three essential aspects of ectodermal dysplasias are: number one, most of the disturbances must affect tissue of ectodermal origin. So most of the skin tissues are of ectodermal origin, which also include the teeth. These disturbances must be developmental. So all the changes must be present from the very onset of the life, and hereditary plays a causal role. The most widely accepted and used definition is the ectodermal dysplasias are the inherited group of disorders that share developmental abnormalities of two or more of the following structures: hair, teeth, nail, and sweat glands. So you must all remember the four primary ectodermal structures in the skin: hair, nail, teeth, and sweat glands. So the ectodermal dysplasias involve at least two of the following four ectodermal structures. Age. The diagnosis of ectodermal dysplasias are made within first year of life, often after complications such as hyperthermia or pneumonia. Sex and ethnicity. Male and females are equally affected, as most of the conditions are either autosomal dominant or autosomal recessive. If the condition is X-linked, then females often have less severe disease. And ectodermal dysplasias are observed in all parts of the world and in all races. There are a few associated diseases that include atopic eczema, allergic asthma, allergic rhinitis, and food allergies. Pathophysiology. Full-blown ectodermal syndromes result from a mutation in an ectodermal key gene. The main ectodermal key genes are ectodysplasin, wingless, P63, and sonic hedgehog. All inheritance patterns have been described that include autosomal dominant, autosomal recessive, X-linked, and mitochondrial. There are 9 different types of ectodermal dysplasias. Most of the ectodermal dysplasias have the features which are present in their names. These ectodermal dysplasias we are going to discuss subsequently in this lecture. The first of the ectodermal dysplasias are the X-linked-hypohidrotic ectodermal dysplasia with immunodeficiency. So as the name signifies, this is an X-linked disorder associated with decrease in sweating and with associated immunodeficiency. So the clinical hallmarks are hypohidrosis, which is, of course, the first and foremost feature of this syndrome, delayed teeth eruption, coarse hairs, and immunodeficiency, which is complicated by frequent bacterial infections. The comorbidities include inflammatory bowel diseases, rheumatoid arthritis, lymphedema, and osteoporosis. Transmission is by X-linked recessive trait in patients with mutation in coding region of Nemo gene. It means that the disease occurs mainly in males and spares the female. There is lack of normal hair growth. Many patients fail to thrive and have fever of unknown origin, mainly because the child is heat intolerant because of the hypohidrosis. Missing teeth and malformed teeth is also a characteristic clue. There is another typical feature of hypohidrotic ectodermal dysplasias that the nails are minimally involved. So the brunt is on sweat glands, then on hairs, then teeth, and nails are minimally involved. There is recalcitrant seborrheic and atopic eczema like eruptions and intertrigo as well. Then another related syndrome of ectodermal dysplasia is hypohidrotic ectodermal dysplasia. So this syndrome is different from the first one, that this is not X-linked, but other features of hypohidrotic ectodermal dysplasias which are outlined before are also present in this syndrome. And the disorder is characterized by hypotrichosis with fine, slowly growing scalp hair and body hairs and sparse eyebrows. So hairs are defective. Then, as the name signifies, there is decrease in sweating that leads to heat intolerance and enhanced dryness of skin. Nail abnormalities are seen, but they are less pronounced, and hypodontia with peg-shaped primary or secondary teeth. So if we do a skin biopsy in such patients, there will be less number of sweat glands. Epidermis will be thin and flattened with flattening of rete ridges. Hair follicles and sebaceous glands are variably reduced. There will be hair-shaped abnormalities that include longitudinal clefts, grooves, and transverse fissuring of the hair shafts. Apocrine glands in special sites may be absent, sparse, or normal. Then even the mucous glands of upper respiratory tract may be sparse or absent, and radiographs from the jaw reveal dental hypoplasia or aplasias. Genetic and environmental factor, simple hypohidrotic ectodermal dysplasia is either autosomal dominant or autosomal recessive. Since sweat glands are less in number and there is decreased sweating, the patient is unable to tolerate extremes of heat, and such patients should avoid hot places and extensive physical activities without cooling devices and special clothes. Patients should drink plenty of cool liquids in warm environments. Wearing hats in sunny climate is obligatory. So if we go a little detail in the different ectodermal structures, first is the hair. Hairs are sparse, they are dry and lusterless, and are usually of light color. Barcode appearance, just like a transverse line in a barcode, hairs will give a barcode appearance in a naked eye or under the microscope. In addition to the scalp hairs, eyebrows are also scanty and absent. Light microscopes show variable hair defects, including the twisting of the hair shaft, pili canaliculi, and trichorexis nodosa. Hair on torso and extremities are also absent. So scalp, eyebrows, torso, and extremities, all hairs are usually sparse or absent. The hairs, due to secondary sexual characters, like in beard, pubic and axillary region, are variably present. and even normal. Then the second ectodermal structure are the teeth. Teeth abnormalities range from complete absence, anodontia, to sparse or abnormally shaped teeth. Dentition is often delayed, and erupted teeth tend to be small, widely spaced, and frequently conical or peck-shaped. Nails, as I've told you, are often normal, although onychodysplasias are reported in 39% of the cases. Then the sweat glands, as the name signifies, are severely diminished or absent due to paucity or absence of eccrine glands. Absence of sweating leads to inability to thermoregulate, and hyperthermia occur on physical exertion and warm environment. Heat stroke is the most common cause of death in first years of life. Overall skin in such patients shows marked scaling and peeling, which may be mistaken for collodion membrane in infants. In children and adult, skin is fine, smooth, but dry. Dermatoglyphics are often reduced or even absent. So you can see the sparse scalp hair, sparse or absent eyebrows, then absent dermatoglyphics on the fingertips, and conical or peck-shaped and widely spaced teeth. Complications and comorbidities. The hypohidrotic or anhidrotic ectodermal dysplasias are associated with high mortality, as high as 21%. The complications include eczemas, asthma, wheezing, nasal crusting, upper respiratory tract infection, feeding problems in infancy. Disease course and prognosis. Early diagnosis is imperative to avoid life-threatening complications such as hyperthermia and severe infections. Avoid heat and overexertion is the most important preventive measure. Cooling the body with wet clothes, cool drinks is only effective way of treating the hyperthermia. Orthodontic intervention and meticulous dental hygiene should be started from the very early life. Treatment, exposure of heat must be monitored. Early dental management is important, and patients with immunodeficiency require aggressive management of infection and sometimes hematopoietic stem cell transplantation. Recently, in a few studies, 3% minoxidil 1 ml twice a day is applied with success in patients with hypohidrotic ectodermal dysplasia. After 1 month, patient showed growth of vellus hairs, and after 1 year, dramatic hair growth was observed. So minoxidil 3% of it, or if it is not available, then 2.5% must be tried as a valid and good treatment option in all patients with hair defects. The third of ectodermal dysplasias we are going to discuss are Ankyloblepharon-ectodermal defects, cleft lip, and palate syndrome. Ankyloblepharon is the fusion of upper and lower eyelids. It is an autosomal dominant syndrome, and it is characterized by, as the name signifies, cleft lip and palate, and severe scalp erosion because of fragility of the skin and abnormalities of the ectodermal structures that include hypotrichosis, hypodontia, absent or dystrophic nails, and mild hypohidrosis. So in this syndrome, the 3 ectodermal structures, that is hair, teeth, and nails, are affected, but sweat glands are very minimally affected. The first and foremost are the craniofacial abnormalities that include mid-face hypoplasia with high forehead, small mouth, narrow nose, cleft lip or palate, hypoplasia of uvula, hypodontia and conical shaped teeth, poor hair growth, sparse eyebrows and eyelids, dystrophic nail, hypohidrosis, and hypospadis in boys. Other features erythroderma and scaling of skin, short stature, low intellectual capacity, conductive hearing loss, and underdeveloped lacrimal ducts. Complications and comorbidities. There is chronic otitis media and secondary hair loss. There is atresia of lacrimal duct leading to epiphora, chronic conjunctivitis, photophobia, and corneal scarring. Scalp erosions and chronic scalp infection may be severe enough to warrant a surgical intervention and skin grafting. Managements, emollients and appropriate for collodion-like membrane should be started from the early age. And if the patient have extreme skin fragility, should be handled with extreme care. Ankyloblepharon requires surgical correction. Lacrimal duct atresia also requires surgical correction. Tooth preservation and restoration is imperative. The fourth of the ectodermal dysplasia syndrome we are going to discuss is ectrodactyly. Ectrodactyly is the claw hand. Ectodermal dysplasia, as the name signifies, cleft lip and pain, and palate syndrome. So in this syndrome, the main feature is claw hand with cleft lip and palate. So the features are ectrodactyly, which is split hand or foot deformity, cleft lip and tear duct abnormalities. Abnormalities of epidermal appendages include hypotrichosis, hypodontia, dystrophic nail, and occasional hypohidrosis. So after the first two syndromes, rest of the ectodermal dysplasia syndromes are not associated with severe sweat glands defects and sweating abnormalities. Epidemiology of this syndrome is it manifests at birth or very young age. Both sexes are equally involved as it's an autosomal dominant. The associated diseases include malformation of genitourinary system, conductive or sensorineural hearing loss, lacrimal duct defects leading to lacrimal duct atresia, photophobia, corneal ulceration, keratitis, blepharitis, and entropion, and endocrine pathologies like hypoplastic thymus, hypopituitarism, and growth hormone deficiency. The clinical features, the first is the ectrodactylia or syndactylia of hands and feet. That is the claw hand or the fused fingers, clefting of lip or palate, which was also a feature in the previous syndrome, but the previous syndrome was associated with ankyloblepharon. So this syndrome is associated with ectrodactyly. In addition, there is hypopigmented, dry skin, hypotrichosis, small malformed missing teeth, and nail dystrophies. Except sweating, all the abnormalities are seen. Often sweat and sebaceous glands are missing or reduced. The prenatal diagnosis is made by the lobster claw anomaly. So the major criteria of ectodermal dysplasia syndrome include, and cleft lip syndrome include, the major criteria are the ectodermal dysplasias, which include the defects in teeth, hair, and nail. Then ectrodactyly, cleft lip, and lacrimal duct abnormalities. The minor criteria include renal abnormalities, deafness, mental retardation, and choanal atresia. Management is mainly symptomatic. However, molecular genetic research show improved gene therapy, which is a thing of future. Then the fifth syndrome we are going to discuss is the Tricho-dento-osseous syndrome. Tricho is here, dento is of course the dentation, and osseous means bone. So it's again an autosomal dominant syndrome that is characterized by curly hairs, enamel dysplasias, pitted teeth, and sclerotic bone. So osseous sclerotic bone. Radiograph of the skull shows sclerosis and thickening of calvarium, and long bones are also sclerotic and thickened. Clinical features. Patient have kinky hair at birth, but with age, patients show increasingly less wiry and uncombable hair. So there is no total hair loss, but the hairs are of abnormal shape, uncombable. There is several dental malformations that include enamel hypoplasia that lead to pitted teeth and caries, but there is no enodontia. Fingernails are thin and brittle and peels readily. Again, the fingernails are not totally lost. Sweat and sebaceous glands are normal and skin is unremarkable. The osseous part of the syndrome include the frontal bossing, square jaw, and elongated head because of thickening and sclerotic of the bones of calvarium. Disease course and prognosis. Hair alteration can be ameliorated over the time. Affected individuals are healthy but lose most of the teeth by age of 30. The investigations, confirmation of clinical diagnosis are made by mutation analysis. Treatment include appropriate dental care and restoration. Then trichorhinopharyngeal syndrome. Here it is hairs, nose, pharyngeal syndrome. So the characterized by malformation of the hair and nail, which are the ectodermal structures. Then other abnormalities are the facial abnormalities and cone-shaped epiphysis of middle phalanges of some fingers and the toes. It is inherited as an autosomal dominant and caused by a mutation of TRPS1 gene. So clinical features, the skin appendages, as already explained, there is fine, sparse, slowly growing scalp hairs, sparse eyebrows and lashes and body hairs, and brittle, slowly growing nails. Then there is a pear-shaped or bulbous nose. So nose abnormality, then thin upper lip, hypoplastic mandible, mid-facial hypoplasia, microcephaly, small and supranumerary teeth, large and protuberant ears. So lots of facial abnormalities are seen because it's a pharyngeal syndrome, rhinopharyngeal syndrome. The skeletal abnormalities include the short metacarpals and phalanges, bulbous end of metacarpals, cone-shaped epiphysis. Other abnormalities include the melanocytic nevi, growth retardation, and mental retardation. Then the seventh syndrome is hydrotic ectodermal dysplasia. As the name signifies, there is no abnormality of sweat glands, so we expect the abnormalities in other three ectodermal structures. It's a rare genodermatosis, mutation in connexin gene, characterized by hypotrichosis and brittle hairs, dystrophic nail and clubbing, variable keratoderma, hyperpigmentation over the joints, and teeth normal. So in most of the syndromes we have discussed till now, there were always some abnormality of the teeth, dentation, enamel, either sparse teeth, conical teeth, peg-shaped teeth. But in hydrotic ectodermal dysplasia, the teeth are normal, sweating is normal. So the two structures that are affected mainly are the nails and the hairs. Sparse hairs and dystrophic nails are seen in early life. Continuous hair loss may lead to partial or total alopecia until puberty. It's an autosomal dominant inheritance, so both sexes are equally affected. The pathophysiology is a mutation in B-gap junction protein gene, which is located in chromosome 13q12 and codes for connexin 30. Clinical features, as already stated, patient present with partial or total alopecia. Eyelashes are short and sparse. Eyebrows as well as pubic and axillary hairs are also sparse or absent. Nail may be whitish. In early childhood, have tendency to thicken. Thick nails, white or yellowish, may be malformed and small. There is variably expressed keratoderma. Pronounced dermatoglyphic exists on fingertips. Hyperpigmentation is seen on the joints. So such type of yellow, thick and small nails and brittle and short hairs. Management with keratolytic and emollients for palmoplantar keratodermas. Alopecia vix. There is a report that tretinoin acts as mitogen by itself and enhance absorption of minoxidil, which acts by enlarging the miniaturized hair follicle and can be effective in hydrotic ectodermal dysplasia. So the seventh syndrome we are now discussing is focal dermal hypoplasia. It's a rare genodermatosis that affect tissues of ectodermal and mesodermal origin. So this is the first syndrome in which, in addition to the ectodermal structures, the mesodermal structures are also involved. It is inherited as X-linked dominant. So it is associated with mutation in porcine gene on X chromosome. The syndrome is characterized by cutaneous, skeletal, dental, ocular, and soft tissue defects. Patients are usually born with multiple malformations, and diagnosis is possible at birth. Since it's an autosomal X-linked dominant, so it is lethal in male. So less number of, or rather 10% of males are seen affected with the syndrome, and most of the affected individuals are female, that is 90%. Clinical features are reddish or red-yellow cribriform atrophic skin, hyperpigmentation or hypopigmentation, and telangiectasias. It is mainly in bleschkoid linear distribution. Their linear enamel hypoplasia is also seen. Ocular abnormalities seen in 40%, which include coloboma, strabismus, microphthalmia, and nystagmus. Skeletal changes include syndactyly, polydactyly, lobster claw deformity, and osteopathia striata. So these are telangiectatic syndrome and lobster claw, syndactyly. Children should be presented to dentists and ophthalmologists as soon as possible. Orthopedic specialists are also important in treatment. In addition, there should be psychological and behavioral management. Then last of the syndrome I'm going to discuss today is the MIDAS syndrome. MIDAS syndrome stands for microophthalmia, dermal dysplasia, and sclerocornea. It's an X-linked dominant disorder with male lethality characterized by unilateral or bilateral microophthalmia and linear skin defects that are limited to face and neck. It's a very rare disease. It is complicated by cardiac malformation, by hypoplastic corpus callosum, abnormal myelination, microcephaly, and mild to severe mental retardation seen in 25%. There is hearing loss, there is diaphragmatic hernia, anterior placed anus, imperforated anus, and genitourinary syndrome. Clinical features, the most consistent clinical features include microophthalmia, anophthalmia, sclerocornea or corneal opacities. Congenital linear skin defects in bleschkoid distribution and nail dystrophies may occur. Management include eye and skin problems should be managed by specialized institutions. Patient with MIDAS should be checked for cardiac, urogenital, and central nervous system abnormalities. Learning disabilities should be evaluated in early time. So the last two ectodermal dysplasia syndrome, that is focal dermal hypoplasia and MIDAS syndrome, are associated with multiple structural abnormalities, and in addition to ectodermal defects, there are mesodermal defects as well. So that ends the lecture today, and hope to see you next week with another edition of my lectures. So goodbye and have a good weekend.